Welcome to the very first episode of Destigmatizing Psychosis, a podcast presented to you by the class of Psych 11Q at Stanford University. My name is Riley Zwetzlow, and today we're going to dive into some topics surrounding psychosis that aren't talked about nearly enough in the media or in day-to-day conversation. Our goal with this podcast is to correct misconceptions about psychosis and to shed light on some of the more sensitive topics surrounding the issue. My guest today is Dr. Jacob Ballon of Stanford University. He specializes in the treatment of people with psychotic disorders, including schizophrenia, and is the co-director of Stanford's Inspire Clinic, which provides interdisciplinary care for those experiencing psychosis. He is also the co-division chief for general adult psychiatry and psychology in the Department of Psychiatry. Dr. Ballon completed his residency in Stanford in 2009 and Schizophrenia Research Fellowship at Columbia University in 2011. Good morning, Dr. Ballon, and welcome to Destigmatizing Psychosis.
Thanks, Riley. Appreciate you having me.
Thank you so much for joining me. Dr. Ballon, in your experience, what are some of the most common misconceptions about psychosis and schizophrenia you encounter, and how do you address them in your practice and teaching?
Sure, that's a great question. I think the first and probably largest misconception and one that maybe leads to the most sort of downstream consequences is a mistaking the psychosis with psychopathy, which is to say that those are words that sort of sound similar. Psychopath and psychotic and psychosis all sort of sound similar, but they have notably different meanings, and it's really important. And people who experience psychosis, they may hear voices, they may feel paranoid, and they may at times, in fact, be violent, like somebody who is a psychopath. But it's exceedingly rare, and it's the exception, not the rule. And so to conflate the two often links violence and aggression with psychosis in a way that isn't fair. In fact, people who experience psychosis are much more likely to be the victims of something violent than to be the perpetrators of violence. And so that misconception around the likelihood of danger underlies a number of kind of downstream consequences for people as far as, is it safe to be their friend, and can, these be people who can work and go to school and do all the kinds of things that we might expect them to do, and leads to a lot of other stigmas that can really hold people back. And so that certainly is one. I mean, I think there are a number of other misconceptions. We could spend the whole time probably on this topic. What I would say is that there's also a thought, when we see people who experience psychosis, often, in the community, often your attention is drawn to them because they're having a bit of a crisis, or there are people who, for one reason or another, have been unable to stay in some form of treatment. You're seeing the most extreme cases in general, right? So if you think about, if you're in the city and you're seeing somebody who's kind of talking to themselves and disorganized, maybe yelling, that's the impression you may get, because that's what you're seeing. The media perpetrates that as well, right? That's kind of the impression that, is often in the news. But in fact, people who experience psychosis can fulfill all kinds of different roles in society. I treat people who are engineers at all the local technology companies. I've treated people who are on the faculty and staff of this university and others. You would walk past many of my patients and you would have no idea that they're people that are taking medication or that have struggled with psychotic symptoms in the past. And so our perceptions, though, are guided by what we often see. And because you wouldn't recognize that as very obviously what somebody with who has psychosis, it's just not gonna put into your sort of memory bank in the way that it is for me, because I work with those people very carefully.
Yeah.
And so I think that when we look at misconceptions, it's both violence and it's poor outcome in life and inability to find success, to find relationships, that people both internalize as, like, if they are told they have schizophrenia or they have psychosis, they think, oh my God, this might be what's going to happen to me. But that as a society, we also put that onto people and think this is what's likely to happen from them. And that both of those together perpetuate these, what we call internalized stigma and externalized stigma, that holds people back and can be really damaging for people, and can cause families to be very worried about what the future for their loved one, in a way that they need to be concerned perhaps for their health, but not worried in that same sort of way that this is going to be a an automatically bad outcome for things. So I would say those are the two biggest areas that I focus on with people, and that we want to make sure we're providing education from the very beginning to both the identified patients and the families, to make sure that they're not falling down those kind of rabbit holes of doom and gloom.
Yeah. Do you think that patients who have been diagnosed with schizophrenia also kind of feel the internalized stigma? Do you think that's kind of a factor when they get their diagnosis as well?
Without question, and it's changing over time. As I think overall, as a society, we're learning more and more about mental health and mental illness. Schizophrenia is kind of the last, I think, to benefit from that. But I would just say that people still often have that internalized stigma of, you know, I can't do certain things. I'm never going to be able to do certain things. My life is over. People, no one's going to love me. No one's going to want to hang out with me. My friends aren't going to want to be with me. Remember, it's also probably being perpetuated by voices that people are hearing, which are also often self-demeaning, right? And so it takes a lot to overcome just that. But if you add in what sort of society puts onto people and what we take on for ourselves, it can be a lot to overcome.
Yeah. Um, and considering the role of trauma and stress in the development and progression of psychotic disorders, how do you integrate this understanding into your treatment approach at the Inspire Clinic?
Yeah, that's a good question. I mean, everybody comes to treatment through a different path. And so many people experience trauma, many people experience psychosis, and a majority of people who experience psychosis probably have experienced trauma. But trauma is so endemic in our population that it's hard always to know exactly what the role is of trauma in the development of a person's mental illness. And trauma can essentially lead to just about everything in psychiatry. Depression, psychosis, anxiety, you name it. Trauma is potentially going to be a strong and likely what we call comorbidity. That's something that occurs together.
Mm.
So we certainly, what we're doing in the Inspire Clinic is we're trying to really focus with people on what are the areas of distress. And often there's a huge overlap with trauma that they may have, and they may have post-traumatic stress symptoms and things like that. But also the symptoms themselves can cause a lot of distress. And that the more that people are able to get in control of the distress, it diminishes the power of the symptoms that they might be experiencing. And so, for example, if somebody is hearing voices and those voices are saying negative things to them, they're telling them that they can't be successful. That's pretty frightening. You imagine if you're a student and you're trying just to get through school, and the voices are telling you you can't do that, and you have this image of what your life is going to be like, and you see it sort of not going there. That's very distressing. Well, if people can work on sort of managing the distress that they're feeling, figuring out how to kind of get back on track, it may take some time, and it may take some adjustment, but to get back on track as best they can with what they were doing, well, the ability for the voices to continue to throw people off is diminished. That doesn't mean it's true for everybody, but for many people that can be really helpful. So managing distress, the medications that we have can help diminish voices, but they often don't take them away in completion. But where they can be really beneficial is that they can help diminish the power of the voices. And then alongside doing things like cognitive behavioral therapy, where people get skills to think about how to manage distressing situations and to reframe certain automatic thoughts they might have, put together, can really help people move forward. So that's what we really try to focus on. And trauma at the root of that, or other stress, is often just part of the overall package that we're thinking of.
Right. Thank you. And in your view, how does policing practices like involuntary hospitalization affect individuals with psychosis? What changes would you recommend to improve how these individuals are treated within the broader healthcare and legal systems?
Yeah, it's really hard. That's really, really hard, because it is true that people with psychosis face discrimination. They face discrimination from the police and the community.
Right.
Other areas, other factors that and other groups that face discrimination. If when it comes to the police, racial categories and things, people, um, people who face discrimination. Maybe rephrase. You can edit it out. People who face discrimination from the police, uh, if you add psychosis to the picture, that increases significantly. And
Right.
so what we know is that we have to be very careful if we want to involve the police in community, emergencies with patients. Now, many police departments have begun to institute mental health divisions, where they will send a police officer alongside a mental health clinician to help de-escalate a situation, to help inform the policing of that situation. But the police can often be at a disadvantage when they're heading to a mental health emergency and the person is not necessarily following directions or able to. It can be very terrifying for police officers as well, and we know that many bad outcomes have happened at the hands of the police, sometimes because of discrimination and sometimes because of the fact that things happen really fast, and when people's behavior is unpredictable, it can be really hard to be a police officer in that situation. So we certainly want to make sure that we're educating our police officers as best as possible, that if we are involving the police, we're trying to give as much information about what the situation might be, that this person is not armed but is in distress. And then involuntary hospitalization is, again, a very difficult topic. There are definitely times where an involuntary hospitalization leads to a tremendous turnaround in a person's life.
Right.
And there are times where an involuntary hospitalization can be very traumatizing. And it's really hard to know. We have to use it very judiciously. An involuntary hospitalization is really only allowed in cases where there's an imminent risk of suicide or of violent behavior, or that a person is demonstrating that their mental illness is getting in the way of them being able to provide safely for themselves, for food, clothing, and shelter. So those are pretty high standards, but they're not, necessarily impossible to meet. And so people do cross those lines, and it takes a certain amount of um, experience to recognize the severity of it. Sometimes people can do very, very dangerous things when they're in the throes of a severe psychosis, and that doesn't mean that's how they're always going to be, or that that's how it always will be for them. And so to be able to make sure that they can't do something irrevocable, a hospitalization can be very beneficial. Also, maybe it's a chance to reset treatment for people, and a chance to get back either on taking medication or on track with other treatments, to just have a pause for a little bit. So, it again, it doesn't mean that it isn't necessarily traumatizing in those moments for people. And hopefully police departments that are working with mental health clinicians are able to help people get into the hospital in sort of a more humane way. Historically, it was, treated the same as an arrest, and people were put
Yeah.
in handcuffs. That can be embarrassing. It's frightening. And again, in the midst of experiencing significant symptoms, if that's the way you're treated, it criminalizes your illness in
Right.
essence, right? And that's not what we want to send. But people do have to maintain their sense of safety, and so hopefully we're turning the corner towards being able to get, help people come to treatment in a more humane way, because ultimately that's going to benefit them in the long term. If your first taste of treatment is antagonistic and contentious and potentially feeling criminalized, then it's really hard to trust going forward. That being said, many people who do come in that way, when things do start to settle down, recognize that this is an opportunity for them to turn things around and to get back on track with what they would rather be doing,
Right.
and the results can be incredibly beneficial. So it's there's no perfect solution, but it can be very hard. But it is certainly not all bad to have people come in when they're not otherwise thinking that they're ready for it.
Yeah, it definitely seems like a hard distinction to make. We've had guests come into our lectures before, and some have said that being forced into hospitalization was like the life turnaround that they needed, like the help that they wanted. They didn't realize they needed it at the time, but ended up helping them in the long run. Versus like what you were saying, some of those, like if you're in handcuffs, that could be super traumatic to start your treatment. Um, who gets to make that decision about if someone gets involuntarily hospitalized?
Well, there are people who are empowered with that decision, and so the decision in California, these are state regulations, so it varies state by state. In California, a police officer is empowered to make the decision to bring somebody in the hospital.
Okay.
Um, psychiatrists, social workers who are trained specifically. I mean, everybody has to go, who, just because you're a police officer, you still have to go through the proper training to understand the rules, but virtually all police officers are trained to do this. But the decision ultimately is initially for 72 hours in California. The standard is intended to be a little bit more broad, and the longer you want to keep somebody involuntary in the hospital, the standard rises. So to bring somebody in the hospital, you have to have a serious concern that they're a danger to self, danger to others. You don't have to prove it. You don't have to, there's not really a due process for that first 72 hours. You have to be able to state why you are concerned, but you don't have to go before a hearing or other sort of due process. Beyond that, 72 hours does require speaking with or going through a due process where patients have advocates that can represent them, and officers of the court help decide if it's actually warranted or not. And it has a more of what's called a probable cause standard, which is kind of the same level of standard that you need to get like a search warrant for somebody, right? And then beyond that, it goes higher and higher sort of levels of needing of proof that this is a person who needs involuntary treatment and it gets very complicated depending on if it's for concern for harming others versus what we call grave disability. If a person is a danger to themselves, it actually ends generally after about 31 days of hospitalization. So again, in California, that is often the limit. But it, again, very state by state. And all of this time, people are expected to be in treatment. It doesn't necessarily mean they have to take medication. There are different standards and statutes that govern when a person has to take medication over their objection, and that's again another relatively high standard to have to prove, and comes with all anytime you deprive somebody of their rights, whether it's in a criminal setting or in a mental health setting or in any other setting, if it doesn't really affect you personally to feel like this is a really challenging thing to do, then you're not in it enough. So we take it very seriously, and it is a very hard thing to do. And because I've had so many experiences of people for whom it was the right thing to do for them ultimately, that have thanked me afterwards. I am able to feel like I'm able to do the right thing for folks, and that doesn't mean that it's true for everybody, but that's the majority of people that I have had a chance to take care of, have certainly at the end of their involuntary period come to recognize what the decision was and why it was made.
Yeah. Does that process include reaching out to family members of the patient as well?
Yeah, it generally does. I mean, if they're available, and in fact, for a 72-hour hold, it often can be enough of the evidence of from family members of expressing their concern, and so hopefully all mental health treatment is in a family and social context. Right. And you want to make sure that people are young people, that their parents are aware of what's happening. That doesn't mean that if you're over 18 you're not an adult and able to make your own decisions otherwise, right? And you don't have to agree with your parents, and their parents don't have full say over what happens. But I often tell people that the patient has at least 51% of the vote for what's going to happen. That doesn't mean they have 100% of the vote. Parents are influential. I'm hopefully going to be influential, but at the end of the day, they have veto power over what's going to happen. And that's true because a person either puts a medication in their body or they don't, and a person either sits and participates with psychotherapy or they don't. And you can't really long term coerce or force someone to really do that in a meaningful way outside of an acute emergency, right? And so you have to work together, and family is often or friends or other loved ones or other people who are important but that are in a person's community can all help shape those decisions.
Great, thank you. Moving on a little bit more to integrating cultural perspectives in treatment. In your practice, how do you incorporate patients' cultural backgrounds and beliefs into the treatment and management of psychosis? And do you have any examples of how cultural understanding has influenced treatment outcomes or patient engagement at the Inspire Clinic?
Sure. I mean, it's a hard one, right? Because people, especially in any area, but especially in the Bay Area, come from such a wide range of cultures.
Right.
Um, so I think the first and most important thing is to maintain a sense of curiosity and openness around, well, what might be uh, reflective of a person's background or culture and how they're interacting. Whether it's how the parents are setting expectations, or are people living in a more intergenerational context where they're more likely to fall in line with what the family expectations are based on culture, or are they living in a more individualistic context where they feel more empowered to make their own decision and also suffer their own consequences for those decisions in a different way. Um, and so one recommendation is not necessarily going to be applicable to everybody.
Mm.
And so it does take time working with families. Sometimes that is hard, especially when you realize after a certain amount of time that what you thought was good advice was actually maybe a mismatch culturally.
Mhm.
And you're operating at kind of loggerheads, and you realize, okay, wait a second, I need to step back and sort of rethink how to discuss this, or what the expectations might need to be.
Mhm.
um we work very carefully with a number of clinics at Stanford that are more focused on cultural aspects and different communities. So if the Inspire Clinic is largely focused on the treatment of people who experience psychosis, we also have things like Smart Clinic, which is not necessarily related to a particular diagnostic group, but the Smart Clinic is focused on treatment of Asian Americans, or La Clinica Latina that's focused on Latinx population. And we have other clinics that we can work together to say, okay, it seems like maybe there's a cultural challenge here. Is there something that we ought to know? Or in the case of Clinica Latina, all of those clinicians provide treatment in Spanish. And
Mhm.
so, could maybe it's helpful to have an interview with a patient or a patient's family in Spanish without needing to use an interpreter.
Right.
Um, and so one of the things we do in the Inspire Clinic is we try to have a lot of our clinicians cross-trained in a number of different other clinics. So some of those folks are cross-trained, and they work in like Dr. Who works in the Smart Clinic, Dr. Beck, who works in the Clinica Latina, and others who can go back and forth and help either provide some consultation there. We also have people who cross-train and work in clinics that uh, you know are other comorbidities, like people who work in the depression clinic or work in trauma and things, so that they can help make sure our patients who experience psychosis can get good care uh, across the whole department. So we try to spread our wings. That way we can help teach people about psychosis and how not to be sort of in too much fear about what that means to work with somebody who's experiencing psychosis, but also to make sure that our patients are understood in other contexts where they may go.
Right. And from your perspective, how does cultural stigma around mental illness, particularly psychosis, impact patient experiences and treatment pathways?
Well, I think it gets back to our beginning conversation about
Mhm.
around, what are the misconceptions, right? Because if the cultural stigma is that people might be violent if they have psychosis, then the expectation is that we need to sort of section people off and put them in some other kind of place. But in fact, for me, one of the most important treatments is actually helping people to stay involved in the community and to be around other people and to work with other people and to try to stay doing some school or competitive employment, so that they can maintain those social contacts and maintain some of the hope that they might have for their future and what they're trying to do. So I think that the more that we can work on with people, whether it's employers or schools, to help make it available for people who've experienced psychosis to stay engaged, then that's really the best thing that we can do for them.
Do you think there are certain instances in which the cultural background kind of limits people's engagement with the Inspire Clinic or yeah, patient engagement?
Sure. Well, I mean, the Inspire Clinic, by its very nature, is situated in a Western medicine hospital,
Right.
right? And so, people who are less likely to want to engage in the services from allopathic Western medicine, uh, they're going to potentially not necessarily think that the Inspire Clinic is the place for them to go right away.
Mhm.
We want to try to do outreach in the community to help people understand that we're here to see them for who they are, and to understand what they might bring to the engagement. But that is going to keep people away. We function within a medical model. That doesn't mean that everybody in the Inspired Clinic uses the medical model at its background, but by the nature, again, of being part of a Western hospital, that tends to be how we think about diagnosis. And so there's a number of different ways that one might conceptualize from around the world, how to do these kinds of treatments, and how to conceptualize of what psychosis might mean. And so we always have to be mindful of our position, of where we're coming from, and what our life experience in the clinic brings to it, and hopefully we bring people from a diversity of backgrounds to our team to help make sure that we're able to kind of capture as much as we can from around the community. But we're never going to be able to meet everybody, match everybody in that way. So we have to really, again, maintain that genuineness, curiosity, and openness to understanding what people's distance traveled might actually be.
Great. Dr. Ballon, thank you so much for joining me today on the very first episode. I'm so excited to talk with you. I just really appreciate everything.
Yeah, my pleasure, Riley. We'll look forward to hearing the final product.
Yeah, thank you so much.
All right. Sounds good.